Okay, this is going to be my denture fabrication, all the steps of how to make a denture video, aka final for the Edentulism Part 1 course. Here's my first slide, denture fabrication. I put a bunch of pictures up of me and friends and family and dogs, and look at all those teeth that are showing. It's important to your smile and to social functions. And look, drinking Starbucks, you need teeth. Or maybe you don't. If you wanted teeth, though, you're here to make a denture. So, moving right along. So this would be a patient, an edentulous patient, or at least partially edentulous, coming for a denture. The first appointment, we're going to evaluate the patient, get our radiographs, oral screening, the works. There's an edentulous mouth right there. So step one with this patient is to get an impression that we first take from a stock tray. There's a lot of details on the slides that I'm going to skip over because that's why I made the PowerPoint to read in detail on my own. But pretty much you're going to load up that stock tray with, well, first adhesive, alginate adhesive, wait a little bit, and then we're going to use in the clinic alginate. And there's a bunch of details about what alginate is, what it does, how to mix it. I'm going to load that up and take the patient's impression. You want to make sure you have a correctly sized tray. And when you do actually take it to their mouth, this is Dr. Durham's P90X technique to really get a good mold of the teeth. So we have lift the lips and cheeks away from the alveolar ridge to allow air to escape as you're putting in the tray. Use moderate pressure to engage the tissues in tray, and then you let the alginate sit there until you could break the remainder alginate in half without it deforming. To take it out, you just lift up their... What is my dog doing? Lift up their cheek, their lip and cheek. This will allow air to exit the alginate, aka breaking the seal. And then after that, you're going to remove it with a quick snap for minimizing deformation. You want to clean this off, and next up, make the dental cast, which you want to pour up no more than 15 minutes after taking the impression. Ideally 10 minutes after, so that the alginate can reshape appropriately from any distortion from taking it out. So there are a lot of different products to use. We're going to use type 2 stone, type 2 model plaster for making our dental cast. That type of stone will give us moderate strength, moderate anatomical reproduction, and it is low cost. And this is kind of what they'll look like on the slide right here. Oh, there goes that thing. So from that, we can make a custom tray, which is just more detail than the stock tray that we first used. We would coat that dental cast with Vaseline and then take a torch to it to melt it around, make sure it's coated the surface evenly. And on that, we will put bisacryl, so it's like triad, and form it around the stone cast that we have. And then from there, we can trim it. It's still really pliable. We can trim it, and we want to trim it short of the vestibule. There's about 5 millimeters maxillary, 2 millimeters mandibular. And once we've got it, the arch all shaped up how we want it to in the triad, we can throw this in the triad cure light thingy, and you let it go around one time, stop it, remove the tray from the stone to make sure we don't get it locked on and cure it all together too fast. Once you remove it, put it back on, and then cure it for 1 full minute. That way we will get it cured, but also be able to take it off the stone. So now we've got a custom tray made, and it's blue here because you coat it with adhesive. So that adhesive is blue, change the color. After coating it, you're going to wash the custom tray with heavy body PVS and take impressions once again. So it says right here, have patient open mouth wide, move jaw side to side, protrude mandible, stick tongue out. And we're trying to reproduce as many possible movements with the bones and the muscles and everything in the mouth in the time that this PVS is setting. Then, once we've done that one time, you can kind of assess your custom tray with the PVS. If you have larger voids that you need to fix, you want to reapply heavy body, wash it over the whole thing, and then repeat those steps. If you have a smaller void or smaller inaccuracies in it, you can use light body and then take the impression again to recreate exactly the detail that we need or that was not captured at first. After this is done, you're going to have the patient lean back, open their mouth, and make sure you have good light and have them say ah over and over until you can clearly define the posterior palatal seal, or where the denture will seal, right in between as the posterior border of the palatal seal is where you're going to mark with an ink stick. This is the vibrating line where you can see when they say ah, exactly where you're supposed to mark it so that the denture doesn't go further than that to where the tissue is moving, but that it seals really well before that point. Once that's marked on the patient with the ink stick, stick the impression custom tray back in so that the ink imprints onto the custom tray, onto the PVS, and then we've got that marked where we need it to be. The PVS needs to bench set for 30 minutes for the hydrogen gas molecules to evaporate and not cause distortion if used too soon. I added in a word on ADA standards that pretty much that there's various amounts of detail that different materials can capture. We do need, to an extent, fine detail to be reproduced. I have the wrong number in here. But so PVS must be able to reproduce a line as thin as 0.2 millimeters in order to be accepted by the ADA. High viscosity PVS must reproduce a line as thin as 0.5. Kind of the point-blank stones will not reproduce to that extent, so we're good with the materials we're using, if you were wondering. Okay, next, step 4 is master cast. So you need to pour the master cast from the custom tray using type 3 or type 4 stone, gypsum stone. The vibrating line that we marked with the ink stick will transfer to the cast, not shown in this picture, from Google. And you can drill on the vibrating line to create a tighter posterior seal. Next up, we need to prepare the wax rim. This is a lot of fun, especially when you've never done it before. So this is a marker of where the teeth are going to go, where we think that they should go, using artistic intuition and science and measurements and our eyes. So there are a lot of measurements to follow. We want the rims. It's helpful if we create them overlapped, mimicking natural anatomy. We want it to be 6 millimeters thick in the anterior, 8 millimeters thick in the posterior. Anterior wax should be 22 millimeters long. Mandibular anterior is 18 millimeters long. There's a lot of measurements to follow that you want to do. Once this is done, we can kind of place it in the patient's mouth and get on the repeatable aesthetic eye level of the patient, and kind of trim up or change what we see fit. This is all a process of getting these wax rims dressed to the nines, which should be explained right here. Yeah. These are the basic instructions of dressing the wax rims to the nines. And I think there's actually updated instructions that we were given on paper, but I don't have that paper. And so this is from YouTube video. Anyway, bunch of meso and microesthetics of how to make the wax rim exactly how we want it. So read through that when doing. We need to obtain a bite record, which is kind of a whole thing with an edentulous patient, since they don't have a lot of guidance of where to shut their mouth exactly. So where they shut their mouth, even in a centric occlusion, could be different a lot of the time. So we're going to do our best to recreate one that's comfortable, stable, that will be functional when the denture is delivered. So we want to orient the patient's head in alert feeding position, which I forget is like 30 or something degrees tilted forward, like as if you're eating food in front of you at the dinner table. You have them positioned in that alert feeding position. You relax their face, showing them how to do it so that they mimic what you're doing and know what you're expecting of them. And you're going to have them close down comfortably over and over onto the occlusal rim. Repeat multiple times until confidence and coordination among landmarks on the rims are certain, so that you feel good that they're shutting down in a reliable way most of the time. You will send these wax rims and the bite registration that we just made off to the lab and send prescription for tooth shade and the tooth shape or type. The lab, which we'll see in a second, will place these on an articulator and send back a wax Try-In. So here's our articulator. Mount casts, and I mentioned here in parentheses that the lab will do this. Thank goodness for lab technicians. So you just get to send this away and forget about what they're doing, but you should know what they're doing. They're mounting those casts that you sent them on an articulator and using the bite record that you sent. So it's important that those things are usable and accurate for them to make the right denture. After this articulator is set, the teeth can be put in by the lab. Setting the teeth, once again, is done by the lab. They follow those 9 meso-esthetic prescriptions when they're cutting into this wax rim. They look at occlusion, balanced tooth arrangement. Oh, I mean that there's different occlusions that they can do. Lingualized occlusions are widely used for functionality and efficiency, although less aesthetic than some other options. Once the lab work has done the lab technicians have done their thing, they're going to send the wax, or like a trial denture for a wax Try-In with the patient. So you would bring the patient back to the office, and you would have like mock dentures to see if this is what you want for the real thing. So I have here, it's a very close replica of what the patient will look and sound like, but a poor replica of what it will feel and function like. So it's really important that you say that to them so that they don't get worried, like, oh my gosh, this is so uncomfortable, like how am I ever gonna chew or close my mouth in these, because this is for appearance and phonetics, not for, comfort and function. Once we get it, though, we can correct errors from the indirect lab work that was done and select the color of the gingiva. Some notes I have here that you can fix short teeth, but it's difficult to fix long teeth, and you might need to start over with new wax rims. You can tweak individual teeth by reheating the wax of the trial denture, and if the midline is off on this, you might need to start over. Whoops. I just threw in a slide for credit to the lab technicians. I watched that little how-to false teeth thing, and there's a lot of cool stuff that goes into it, so respect. And after we've made those tweaks, sent it back to the lab, they fix it, we get delivery of the denture to the patient. We give them their final denture product that they've worked so willingly to get, and we want to communicate expectations to the patient about how long is it going to take to feel normal, and reminding them that they're only going to get 10% of the function that people with natural teeth have. So it's not a cure-all. It does do a little bit, but it's not going to give them full function like real teeth do. We want to check for sore spots with the patient. one at a time, focus on this quadrant, move around, really trim up where it's necessary. We want to check the posterior palatal seal, that it is sealing well. We want to check occlusion and phonetics. As far as occlusion goes, one centric contact per tooth is sought if you did lingualized occlusion. You can check the pressure of the denture with checker pressure paste, and overall checking the ability to speak, their comfort, appearance, uniformity of bite, and eccentric contacts. So this is a note on verifying the sounds. The s, sh, z, and j are very important and can be difficult to recreate with a denture, especially a new one that a patient hasn't adapted to. So I have here, the key is to place a denture tooth such that it will articulate with the wet dry line when a patient says F or V. So you can see that my F right here, wet dry line. Saw it here first, folks. And there's some helpful tables, like this first smaller one. If you're hearing the wrong sound compared to what you want, it has kind of some instructions of how to fix it, what to adjust. And over here, sentences you can ask the patient to say to verify that they are, if they're saying their S is, Sue is missing one piece, you could hear it. And in our live denture making session, even the patient saying that sentence like one time versus the fifth time they said it, they already seemed better at it. Sue is missing one piece. Their S's got progressively clearer as they were able to keep practice saying it. So step 12, okay, communicate instructions clearly. You don't just want to send them out with a denture with no instructions, because this was a lot of work went into making this denture, a lot of time, a lot of money, and so it's something we want to preserve as long as possible and treat really well. So we want to discuss importance of consistently wearing the denture for the first 2 weeks. I think that they likely, if they've been a denturist for a long time, are going to find them rather uncomfortable. As we did with like our selfie denture, can be harder to speak, swallow, bite, breathe, speak, anything. So they're really gonna have to power through those first 2 weeks. And it was mentioned that those who do wear it straight for the first 2 weeks have a better probability of adaptation and lasting success. And this doesn't include at night. You would take them out at night. It takes about 5 months for the body to forget about the denture. Excess salivation should stop by this time, but it might take longer. And you want to go through them with this Kiss in a Denture checklist, and you can read that. It's, going through some things that they would want to be aware of, or what things we need to fix or address. Important is a couple follow-up appointments. So I have like step 13 here is following up 24 hours later after they've worn them, checking for sore spots and cheek and lip chewing. We don't want these dentures causing them harm, obviously. Step 14, following up 1 week later, and once again, you guessed it, checking for sore spots and cheek or lip chewing. I just have a note here, the mandibular denture is similar to the maxillary denture, kind of that's what we focused on, but there are often implants involved on the bottom that will, as Kiss in a Denture tells you, right here, implants make good dentures better. Inform every patient about how dentures are not great, but implant dentures can be better. So lots to learn, and that's how you kind of make a denture. So good luck in lab, Madison. I hope past Madison right here knew what she was talking about and did this in the right order and said the right things.